Asthma is a reversible chronic inflammation of the small airways characterized by exacerbations of autonomous lower airway hyperresponsiveness and triggered bronchospasms, which cause the obstruction and limitation of the airway, essentially causing wheezing, shortness of breath, and limiting the intake of oxygen. The risk factors associated with the exacerbations of asthma include exposure to allergens and allergic disease, exposure to air pollution, recurring viral infections, overexposure to allergens in childhood, and smoking. The manifestations of the asthma attack may differ depending on the trigger associated and responsible for the exacerbation. Mr. Smith presented to the emergency department with clinical manifestations of a chronic asthmatic respiratory exacerbation. The most common form of asthma is atopic asthma, and it begins when an environmental allergen triggers the immunoglobulin E antibodies to begin an inflammatory response within the small airway, causing forced expiratory volume. When the airway becomes triggered by inflammation, it causes the muscarinic receptors in the smooth muscle of the lumen and bronchiole to constrict and tighten, thus obstructing the airway. An abnormal inflammatory response to the allergen is triggered, causing mast cell degranulation and the release of inflammatory mediators, resulting in vasodilation of capillaries, allowing inflammatory cells to move through the interstitial walls. Immunoglobulin E triggers basophils and mast cells to release histamine, interleukins, prostaglandins, leukotriene, and nitric oxide to the site, causing further swelling and thickening of the bronchial area and airway walls. This response results in vascular congestion, edema formations, production of mucus, impaired mucociliary function, and increased hyperresponsiveness of the bronchiole. The narrowing of Mr. Smith's airways from the larynx to the small bronchi has caused severe dyspnea and wheezing, which is generated by the vibrations of constricted walls of the airways when trying to breathe. His chest x-rays show hyperinflated lungs, which is an indication of airflow limitation during expiration, which may be caused by mucosal edema. Trapped air behind the narrowing airway become hyperinflated, causing airflow limitation and thus prolonged expiration. Tachypnea and dyspnea can also be clinically seen, with Mr. Smith's results indicating respiratory distress caused by the impaired gas exchange due to constriction of the bronchioles and decrease in alveolar ventilation, as well as increased airway resistance, making breathing more difficult. Decreased oxygen saturation levels are a clinical manifestation of the impaired gas exchange occurring within the lungs due to mucus plugging of the airways, causing bronchoconstriction and thus the restriction of adequate oxygen intake. Mr. Smith's pulse rate was tachycardic, which corresponds with the manifestations associated with the onset of acute severe asthma. The severity of the asthma can be measured simply by the dose and frequency of pharmacological mediators required to prevent or reduce exacerbations. Treatment for acute severe asthma include a combination of inhaled corticosteroids, anti-inflammatory drugs, long-acting B agonists, and antimuscarinics, which trigger the relaxation and widening of the smooth muscle of the small airway. Short-acting B2 agonists may also be used and useful in improving pulmonary function and bronchodilation. Lung function tests may also be performed in order to review treatment progress and determine the severity of an asthmatic exacerbation. Some tests may include peak flow, spirometry, measurement of nitric oxide, and pulse oximetry.